Hello folks, welcome back to Bullhorns and Sirens. We're here with part 2 with Jon, the Critical Care Paramedic. Let's not hang around, let's get straight into it. We know you want to hear from him. Hope you find this episode interesting.
So we've just talked about how we reflect on our own jobs and stuff like that, but another thing that crews do quite a lot, and I'm sure you do as well, Jon, is a hot debrief. So straight after the job, no matter what the outcome was or where you are, your location, a hot debrief, which is sort of instantly after the job, you'll get together as a team, talk about the job and stuff like that. I'm sure you've been involved in many of these, probably led some. What would you say is the importance of a hot debrief? And then can you sort of like talk a bit more about a debrief, because you probably do quite a lot of them.
Yeah, sure. So obviously the types of jobs that we get sent to tend to be high acuity jobs, and some of them can be quite emotive as well. But on every job, really, it's an opportunity to learn. You know, you can take something from the job and use it to change your practice, maybe, or to influence your practice, or just understand what happened. You know, so I think the purpose of the hot debrief is multifocal, really. But first of all, is to check that everyone's okay. You know, because we do go to some gnarly jobs, and you want to touch base with everyone, and some people. So everyone's a little bit different. You know, some people will feel comfortable opening up, and other people will prefer to be in private, and you can read the room a little bit, and you can sort of gauge individuals and sort of think they've gone a bit quiet. You know, they're tidying up the stuff. They don't want to be in the back of the ambulance with everyone else, and so I won't force people to be part of it if they don't want to, but I'll definitely touch base with them afterwards and sort of just hand on shoulder, just, you okay? You know, like, I noticed that you didn't want to be part of it, and that's completely personal decision, but I just wanted to let you know that if you want to have a chat about it, you know, we can do that behind closed doors, just one-to-one if you want. So kind of make sure everyone's okay, and then kind of get an understanding about what's happened, like headline the job. So this was given as a fall from height, or a stabbing, or a medical cardiac arrest, and then if I'm leading it, then what I tend to do is allow everyone else to speak.
As in, like, you just go around the room and just go, or
just,
the ambulance, or wherever you're doing it. And
yeah.
What do you think? What do you think?
Chronologically, in terms of who was on scene first, let them give their version of the story. So, what happened? What, you know, you were on scene first. What did you find? What did you see? What did you do? And frame it like that, and then go around the room and often the story will unfold, and more information will peter out from individuals, because, like you say, you know, everyone's experience of the job might be a little bit different. They might see something different, they might, you know, hear something different, whatever. But so it's important to get an understanding about what everyone else thought about it and what everyone else felt about it. And then really, you know, if things went well, then it's to identify good practice. It's like, I really like what you did there, you know, I really like what you said to the error, or I really like the way you took control of that scene or that patient. So it's identify good practice, and then conversely, it's like identifying when you can improve on your practice, like opportunities to learn, but also identify how you might do things a little bit differently next time.
Bad practice. No, joking.
No, it's not. Yeah, it's kind of like it's just it's all opportunities to learn, you know, and that's what you're looking for. And sometimes what I'll do, if I know people are holding back, if they're like, you read the body language, and like, if people got cold, you know, folded arms, and they're looking up at the ceiling or looking down in the boots, and so what I'll do to kind of make people feel, what's the word, like psychologically safe in the environment to open up, I'll say, first of all, guys, I apologise. Like, I messed up on this. I didn't do this very well, and like, I just want to use this opportunity and say I'm sorry, you know. But I know for next time that was something that I'll change, you know.
I like that,
and yeah,
because if people see you opening up as that sort of lead clinician that's experienced, you're there, and you're the critical care paramedic, people are sort of going to be like, well, I mean, if he can open up, I can open up. like
Yeah.
they're going to take from your, they're going to be led by you, and
hopefully, yeah. And I always want to be for people to feel like I'm approachable, you know, to talk about stuff, because I know what it's like. I know what that felt like, and I still like make mistakes. You're only good as your last job, and you know, every day's a school day, as you say, you know, and so looking for those opportunities to learn, and the HEMS culture really introduced me to that. You know,
They debrief quite a lot.
Yeah, every job, yeah, and you know, you've got hot debriefs, and then you've got the cold debrief like a week later in front of the team with the consultants, and you learn so much, you know, and they debrief it from the moment you get the call to the moment that you sort of hand over at hospital, and the follow-up as well, and you learn so much, you know, and just being brutally honest with yourself, you know, like you can tell yourself lies, and you can sort of say, I can brush over stuff, but you're really only just fooling yourself, you know. If you really be honest, and it's uncomfortable, but that's where you learn. That's where the growth is.
That's it, like asking yourself those deep questions that you might want to ask other people, but really you should be asking yourself first. That's quite interesting. Do you follow the same kind of structure in every debrief, or do you let it sort of just flow?
I'm not rigid, you know, but I kind of let it flow to a degree, and then but what tends to happen is, if you let it flow too much, people start talking about EastEnders and about X Factor and stuff. So you have to kind of
draw it back.
You have to kind of bring it back, you know, and sort of, you know, refocus the room, sort of thing, a little bit. But it's always a benefit, I think.
I suppose also the difficult thing with, well, it might not be so difficult. I suppose if I do a difficult job, I've got a crewmate that I can debrief with later on in the day about that difficult job.
That's so true.
But you will go, I don't know, from one job, you know, to another, and then you don't have that crewmate to debrief with, say, later on in the day, and then you've also been to 2 really high acuity jobs in between that, and you might still be sort of debriefing about that. So do you go back, can you like call other people? Do you call and debrief over the phone with other people? Just
to give you an overview of how the program works, we've got a critical care desk in control, a functional sort of desk that's always manned 24/7, and that takes priority, and there's a CCP on there, experienced qualified CCP on there, scanning all the calls and finding the right job for the individual CCP in the area, and so they know who's getting sent to what, and so if we're gone to a baby, you know, that's a nasty paediatric job or whatever, or a highly emotive job, they know and they flag it. So there's a system in place for our safety that is kind of flags on the CCD that knows that CCP's like gone to a gnarly job, and you know, they might want to chat about it, and so that's flagged up and then forwarded to our governance, which is every 7 weeks. And we're really lucky to be in a program where every 7 weeks we get together with our horizontal team and being able to debrief these jobs in depth with our peers at the same level. And also we've got top cover consultant that will call in, and we can ask them the difficult questions, you know, because sometimes, you know, these debriefs will not getting any answers and get more questions, you know. You know,
like a Sherlock Holmes mystery.
And we'll come away like, but we're very lucky with the program to have these consultants that know us, know what we do, and have been there, you know, and got the vast knowledge to tap into.
Because that's something that we wanted to touch upon, is the clinical governance within the critical care program, and we spoke earlier about how you can deviate from a guideline. So, you know, in the jail calc it might say, you know, give this amount of adrenaline if their blood pressure's below 100 or whatever, but that might be a bad example, but you understand what I'm saying. And so you can ask yourself those kind of questions within those sort of meetups and stuff. And did you want to talk a bit about the clinical governance within the program?
Yeah, sure. It's a really important part of our program, and we're fortunate enough to have a really robust governance system in place. Yeah, so every 7 weeks, every CCP will be put through the governance system, and we'll meet up in a room, and we'll debrief selected jobs.
Do you select them, or is it like randomly select?
We offer up jobs that have been of interest, that have bothered us, that have gone well, or maybe gone not so well, you know, and opportunities to learn. So, you know, I try and pick jobs that didn't go so well, and then when you kind of break it down and do a sort of root cause analysis of why it didn't go so well, and you can sort of pick up. There's always something that you can go, yeah, that was probably why. Or if not, then you open it up to the group and go, I've got no idea why this went wrong. And then someone else will go, I've been in that situation before, I think it's because of this. And you go, oh, yeah, or whatever. So it's massive benefit. The governance is robust, so we have to do it every 7 weeks as part of the program, because we do some things that are outside normal paramedic practice. We practice our surgical skills, so we practice the surgical airway every 7 weeks. We practice our thoracostomies every 7 weeks, and we go through our electrical kit that we carry. So we practice ultrasound, ventilator settings, and stuff like that. So we're well rehearsed with the specialist
with
interventions.
The kit, yeah, because that's something that we fall back on, especially, you know, you get out, you go to like someone with like a femur that's hanging out of their leg, and you go, right, yeah, we need to traction this. Do you want to get the splint? And then someone pulls it out, and then you go, oh god, how do I do this again? Because we don't go back on these things, where at least, you know, you might not have done a surgical airway before, or whatever, or you might have not done it for a few years, but you know that you've done it within the last 7 weeks. You've practiced it, and so you know you can just go straight into it, and that, which I think that's amazing. But then I suppose the high acuity of the calibre of patient that you deal with, you kind of have to be like really hot on it. You can't really blag what you do, can you, as a CCP? Do you then talk about in the governance? Is it all clinical stuff, or do you just talk, or can you mention about how it made you feel? Or
so we talk about all things that are relevant to our practice, really. I mean, like the last time I was there, I did a little presentation on resilience.
Cool.
You know, that helps with everyone else, because, you know, of the exposure that we get and stuff. And stuff, but kind of going back to some of the interventions that we do practice it every 7 weeks. But one of the things that really helps us as well is mentally rehearsing what we do as well. So we can, like, your imagination is really powerful. You know, you can, and especially when you practice doing it. So you can imagine you go to any sort of situation, and you can mentally rehearse what you're going to do, and you can make it as difficult or as easy as possible.
Yeah,
you know, and so that's quite powerful. And I've learnt that from the sports days. You know, of like imagining, you know, winning the race or like playing, you know, whatever sports and stuff. So that's like a transferable skill. So that's quite powerful. But yeah, we do, going back to the governance. So we debrief jobs, we practice our skills, we moulage. So we go through scenarios. Some of the team go out and they're part of the moulage, and everyone else in the group is relatives, patients, bystanders, you know, police officers, whatever. And we create a scenario, and we try and make it as realistic as possible. And that's something that the HEMS teams do as well. And that's really good, you know.
That's awesome, because is that with all the other CCPs in like the team or a watch or something? Yeah. That's brilliant, and that's quite a heavy day though, no?
Yeah. So it's broken up. So we're lucky we get 4 days of governance every 7 weeks, which is we're very, very lucky. But it is critical to our practice, for safe practice.
100%. Yeah.
Yeah, definitely.
And what else do we do? We review our CMPs or SOP equivalents. So for every advanced intervention that we do, there's a clinical practice guideline for it. So, for example, tachyarrhythmia, we've got a flow chart to it, and that's evidence-based, and that's signed off by a medical director and top cover consultants. So when it comes to someone else who isn't part of the program and doesn't fully understand what we're doing, and you know, wants to question our practice, we can back it up with the robust clinical governance and evidence base. So.
Oh yeah, otherwise you'll just be doing all of these random things and there'll be nothing
Yeah,
behind what you're
yeah,
doing. That's pretty cool.
This podcast is produced and led by the Pocket Clinician team. Please visit our website at www.pocketclinician.square.site to see our range of products, or you can visit our Instagram or Facebook, which is Pocket Clinician. We really hope you enjoyed the second part of this episode. Thanks so much for listening.
What do you do to cope? How do you deal with those situations? What's your own like management and lifestyle for coping with the exposure of the things that you see?
So I'm really lucky. I've got some close friends that do the same job as me, and you know, I offload on them a lot, and vice versa. You know, we understand each other's role. We understand what we see, what you know, we're exposed to, and also they get the context behind it because they're doing it too. You know, and so they get the brunt of it, and I lean on them quite often, and they're great. You know, it's priceless. Outside of work, I exercise a lot. You know, I think that's good for you generally. It's good for, you know, longevity, and it's quite an active physical job anyway at times. So it's healthy to do that, like strength training, HIIT training, that sort of stuff. And I think also what I've read about like resilience and stuff is it's like a muscle that needs to be exercised. You're not born resilient, but the more you're exposed to hard things and to difficult things, the more resilient you become. And it's important, the story that you tell yourself as well. You can label yourself as a victim, or you can label yourself as someone who's growing and getting stronger. And so I try to do hard things as well. I try to like fast. I try to exercise hard. I try to. I've got into cold showers and stuff like that.
I've just got into cold showers because I can't afford my heating bill. So, yeah. But yeah. That's
Have you done ice baths? Do you do ice?
No, just cold showers enough. Yeah. Just dial it down and yeah.
Well, they're good. Like, because this is going off topic a little bit, but someone said about when you drink alcohol, it increases your dopamine levels by 2 times. Cocaine increases your dopamine levels by 2.5 times.
Not that we're recommending cocaine.
No, but an ice bath or a cold shower increases your dopamine by 2.5 times. So you get the same sort of dopamine hit as you would with cocaine, but with cocaine it only lasts for 9 minutes and then it goes below your baseline. With a cold shower or ice bath, it carries on for hours, and that's why it's so. I mean, that's not the only reason why it's so beneficial, but. I mean, that's just something I've read about the dopamine levels.
There's loads of health benefits to it, and I'm all about that, you know. And I find it fascinating. It's interesting, and why wouldn't you? You know, if you know something that's good for you, why wouldn't you do it? And so I listen to different podcasts as well. I listen to there's a guy called Jocko Willink. I don't know if you heard of him. He's like ex-Navy SEAL, but he talks a lot about discipline and he sort of says that it's not motivation that gets you where you need to be, it's discipline. Because, you know, motivation, this comes from him, motivation is like a feeling that comes and goes, whereas discipline is something that you can control. It's like force yourself to bounce out of bed, get in the cold shower, and then you've achieved the first psychological battle of the day. It's not something that you want to do, but it's something that you've chosen to do, and you've got your first win of the day, and now life can throw stuff at you and you're ready, you know.
That's pretty cool. So, sorry, this is really digressing. We'll go back to everything now. But,
no, but I think it's interesting.
So with a cold shower, so I rarely have a cold shower because I hate them. But then with the health benefits, when you have a cold shower, is it just before a normal shower, or do you have a cold shower and that's it?
I started off in January. I thought, right, I'm going to try this. And I dialed down for 10 seconds, like maximum cold. It's horrible. and then I ramped it back up again. I finished my shower, you know, and I washed and everything else. And then so every time I have a shower, I just extended that time.
Oh, okay.
And now I'm getting in like cold tap, fully on, and getting under it. It's horrible. I like do this little dance before I get and like start giggling to myself because I know it's going to be uncomfortable. I know it's going to be, you know, that uncomfortable feeling, but I know that afterwards I'm going to feel great. Not only physically, like my body's going to be tingling, but I've done something I've told myself to do something that I don't want to do.
Yeah.
I've done it, and I feel like I've succeeded. I feel like I've won my first little thing. It's like, you know, making your bed and doing all that sort of stuff. That first little task that you get squared away, the rest of the day you can sort of build on.
Yeah.
How long have you gone for now? Cold shower?
Normal type, like 5 minutes, you know.
Because I've tried doing that. Oh, well, actually, I haven't tried. It's been forced upon me when the tank was when the tank had run out of cold water.
But it's like anything, you know. The body, you know, it adapts to what you expose it to.
Yeah.
You know, and you get it stronger. That's like exercise, you know. If you can keep a record of what you're lifting and try and improve, like if it's 1 rep or just another half kilogram each time, and just adapt, and the body adapts. And if you get the correct rest, nutrition, and you're following a program that's semi-decent, you will see gains. But it's the discipline that will get you there.
God, this feels like a completely different podcast now. I don't know if I can, I know,
But no, because I mean, it's good because we're getting to know, you know, it's how you cope. Like, everyone has their own coping, and for you it's a focus on your physical health, your physical well-being, and how that then reflects into your mental health and your mental well-being, which, you know, so it links back.
It does yeah, it does sort of help me massively. Yeah.
Is there anything else that you do to cope, say, like, I know you do those things every day to sort of build up your mental resilience, but is there anything else that you do at the end of a tough day or a tough week?
I mean, I like a beer, like any, you know, I love a beer.
Yeah.
But it's a reward. It's like a little treat, you know. I do like have the occasional binge, you know, and, you know, like a curry and meeting up with my mates and that sort of stuff. But I walk my dog daily, obviously. He's very needy, and he won't let me rest, which is great for me. And he listens to everything that comes out of my mouth.
Yeah. So even your dog is there to...
If
only your dog can talk.
But that loyalty from a dog is just unquestionable, and it's that's so he's an important part of my life as well, you know.
Yeah. Because I've definitely had issues with my head after like a job, and it's not even that job, it's like weeks after something else happens that isn't even that bad, and then I start having flashbacks, and it's weird, and I've managed to control them, but there's lots of things that in place that we've got to help us deal with those things, and within a couple of weeks it had all gone and it was fine, and apparently it's normal. I don't know.
Okay.
But do you have these experiences, and also do you have like a similar, you must have all of the same things that we have, but is there like a more in-depth, sort of easily accessible, sort of more in-depth psychological support or anything like that? Or does that question make sense?
Yeah, like, do you use things like trim, for example, after a difficult job? Have you ever done anything like that? Or
So one of my colleagues, I had a wobble a few years ago, and not something that it wasn't one event, you know, it wasn't one incident or one job, but it was like my bucket had got full, you know, and was overflowing, and I was not sleeping very well, feeling on edge, irritable, like short-tempered, and that's not me, you know, and that's not me. And I felt bad because I couldn't control it, you know. I thought, I'm not me, you know, and I spoke to a colleague and referred me to another colleague who I love and trust, and she debriefed me with the trim. She was a trim practitioner, and I opened up to, you know, her about stuff, and it was really good, really beneficial. And sometimes you don't know what it is, but when someone else asks you questions, it just seems to come out, you know. It just seems to sort of, when someone else just goes, why were you feeling like that, and you really have to search yourself, but they're there, you know. And it's having someone sit down and really be interested and really want to understand how you're feeling is the key, and you feel safe talking to them, because some people will want to talk to individuals, and the same person won't want to talk to that person. And so there's a list of trim practitioners, and you go down the list and you know all the individuals, and, you know, some people you go, I'll talk to those three, but I won't talk to them, and it's a personal choice, you know.
Well, I guess it's quite a deep sort of moment where you're opening yourself up like that, so you want to do it to someone you know and trust, don't you? You know, you don't just want to do it to someone.
And understands the context behind it.
That's it. Because when it was similar. It was completely unrelated, and also like it was several things that must have just built it up for me. But I didn't want to go to my mates being like, oh yeah, before I was going to sleep, I literally had this image of this guy, you know, whatever. I won't go into too much detail, but because otherwise I didn't want to sound like a bit of a nutter with all of my mates. But then actually, you know, if you talk to someone about it who knows the mechanism and the issue behind it and the reason why you have these issues, then you know you feel more comfortable talking to them about it as well.
Absolutely,
But yeah, no, I think it's awesome, and I think it's important for the people listening as well, whether you're a student or whoever, that deep conversation that you have with yourself before even anyone else, you know, because you can always think about it and go, yeah, it's just a rough job that I do, and I think that's like not a great way of dealing with it. It's asking yourself that deep question, like, why am I feeling like that? And then if you can't get it out yourself, then it's probably a good time to then go to another person.
With previous relationships I've been in, I've purposely not talked about my job, because they wouldn't get the context behind it. You know, like I can try and explain why we did an intervention or something, and why a relative said something that really hurt me, despite me doing my best efforts for their relative, but they wouldn't get it. They wouldn't fully understand it, and so for me that was protective, because I would sort of leave my job at work and then come home and be with you know, a person and live a separate life.
That's it, and it's just a complete two different worlds then, isn't it? And it kind of helps to separate the two, isn't it? So
As for some people that works, and for other people's, you know, they're lucky to have partners that get it. You know?
Yeah. No, that's good. So John, we really appreciate your time, and thanks so much for coming on to the podcast. You know, it's been inspirational, to be fair, talking to you, and I really hope that the listeners get the same inspiration that we've got listening to, you know, your anecdotes, your advice on different things like coping, and also I learnt quite a lot just listening about how you want crews to manage post-ROSC before you get there, you know, and that's quite interesting. We put on our Instagram that you were coming today, and we said if there's any questions that you want to send them in and we'll ask them.
And then everyone was like, sorry, who is he?
No, not at all. So we've got 2,000 questions to go through, John. No, I'm joking.
How much time have you got? Yeah.
No, we got. So we picked out 4 questions that we thought that was quite relevant and good to ask you, that we might not have covered throughout the podcast. So the first one is, how competitive is the journey to becoming a HEMS CCP?
A HEMS CCP, depending on the characters, it is very, very competitive. You know, some people not interested. You know, they're happy. They want to do primary care. You know, they want to specialise and do something else. They're happy being a paramedic, a good paramedic. You know, some people being a good ECSW, and that's commendable, but the people that want to specialise and go on to CCP/HEMS, it is very, very competitive. But that being said, it's like for any good paramedic, you can get it, you can do it. If you really want it bad enough, if you really want it, you can do it. If I can do it, you can do it. And it's the old thing, isn't it? You know, you can. There's only certain things they can test you on, and so I knew that it was going to be a steep curve for me. I'm not that smart. I'm not that intelligent. I've worked hard to get to where I am. And if you told the 12-year-old version of me what I'm doing now, I think I'd be pretty stoked, you know, to find out what I'm doing. And I would have probably gone, no way, you know, because that just wasn't me at the time, you know. But it just shows you that with hard work and with discipline, you can get to where you want to be. And I suppose for advice for people that do want to do HEMS CCP is to immerse yourself in it, to ask lots of questions and start preparing now for it. Because if you wait until you're shortlisted, it's too late. If you want to be HEMS or CCP, surround yourself in it, ask yourself those sort of questions, and mould yourself, you know, and make yourself one, you know, because you can do it. You can certainly do it.
No, that's so true, because I know guys that want to be a CCP, and they're doing the CPD courses, like they're doing trauma courses, they're doing, you know, all these sort of special circumstances in cardiac arrest courses, and then they almost make friends with CCPs as well, and it's, I don't know, it's quite an interesting sort of way to do it.
It's almost like a lifestyle choice, isn't it? Once you know that's the route you want to go down, like you said, you have to really immerse yourself in the culture and realise this is it, this is my path, I'm going to do everything I can to get there, so you've got to give 100%.
Before I went on to HEMS, I was always going down to the HEMS governance. They opened it up to outsiders, and I would be, you know, amongst it with the moulages and listening to the debriefs and making notes and asking the HEMS paramedics questions, you know, just sort of being there and just surrounding myself and really kind of allowing it to get into my veins, you know. Really helped me understand the culture and understand how I can get there.
No, that's awesome.
So our next question for you is, how do you manage or cope with doing a normal road shift after doing so many CCP shifts? And do you get the chance to go back and do just like ambulance shifts or?
Yeah, I do, and I try and consciously do it, but I'm smiling to myself because it's like anything that you do regularly, you get good at it, but also equally, when you don't do things for a long time, you lose touch of it, and you don't feel so slick. So I'm careful who I pick my shifts with, because I don't want to burden them with my incompetence. But it's a good question. Yeah, like I try and do 1 or 2 a month, and you know, I get a better appreciation of what the crews are going to, and to see what they're kind of exposed to and stuff. So I lean quite heavily on who I'm with, in terms of pathways, in terms of like falls not injury. You know, I lose a little bit of guidance with that sort of thing, but it's not like, but between me and my crewmate, we get through it, you know. And it's refreshing, you know. It's a nice break from going to resus after resus and like major trauma and stuff. And actually, I do miss speaking to the elderly, you know, speaking to, and getting into their heads, like, because you always find them interesting, you know. You can always find like, what do you used to do for a living, like, you like, and get into their world a little bit, and I think they appreciate it too, just to chat and stuff, and particularly the people that have looked after themselves. Like, I'm really interested in that. So I went to a 91-year-old who had fallen down some stairs. Fortunately, he was uninjured. He got himself up and walked in, but it lit up on the CAD, and it was like, and he was fine. He was like sitting on his sofa, GCS 15, but he looked about 65.
That's mad, isn't
it? Yeah, and I was like, what's your, you know, what have you done? Yeah. And I'm intrigued. It intrigues me. And he says, you know, I walk every day. You know, I've always had a dog, and you know, I always have like close relationships and stuff. And
cold showers.
But a lot of it, you know, it's genetics, some of it, but I think you can influence a lot with your lifestyle. But yeah, I find it fascinating, you know, and sometimes I might zoom out of the patient's condition and go, oh, who done your decorating, you know?
This is so true. You walk into like a job, right, and then you get about like 10 minutes into it, and you've gone through like all your history taking, and you just sat there doing a bit of notes, and then he'll just pipe up with, kitchen's nice, or he'll come out with, do you recognise me? And the patient will be like, oh no, why? Oh, I've been on the telly a few times. Like, I swear that actually happens. Like, oh, it's a fun shift whenever you work with John.
Well, I do that as well, because sometimes I just go around their house and go, oh, it's a nice garden. Like, how do you maintain that? You know, at your age. Oh, we got gardeners. Oh, okay, fair enough. And you know, it's just little questions like that, and I think it makes it more human, doesn't it?
Oh, absolutely. Yeah. It stops you just being this person in a uniform that's coming to a random person's house. You're trying to build that rapport with someone, aren't you? And
that's it. But no, I think that's a good answer, really. And I remember being a dispatcher, and I was dispatching you one night, and the rule at the time was this was when like the ambulance service just started getting really busy, and no one really knew what to do about it. So what they started saying was right, send CCPs to normal jobs. You use them as a single resource, right? And you're like, no way can I do that. And anyway, so I held John back, and I was like, no, I'm not sending him to this. So I'm holding him back for a CCP job. And then about 3 hours into my shift, I got a tap on my shoulder. It was my manager, and he said, what is that CCP doing at the station? You're holding jobs out there. You need to send him out. Okay, fine. So I ring up John, and I'm like, oh mate, I'm really sorry, but I've had a manager now just say that I'm gonna have to send you out on this job. I've got, what do you want? I've got a full non-injury over here, and he said, yeah, sure, no worries. He goes, look, I understand. You got to do what you got to do. He said, but he said, I might take a lot longer than usual because I don't really see patients that are alive, really, like that sort of thing. And I thought, bro, that's so true, isn't it? And yeah, I don't know, it's so true. And I don't know if you remember that night or not, but I thought it was the turning point for me when I thought, what is the ambulance service going through? And if you're so used to,
well, this is it, like the severe unwell, not the minor illness, minor injury. It's hard to adjust and adapt, and
that's the idea about the CCP program is to have that that whole setup of getting people that want to do that sort of job, put them through a selection process, put them through education, put them through placements, put them through clinical governance, have top cover doctors, clinical management plans, and then sending them regularly to those patients. You're going to get better at it. You're going to get pretty slick, and that's the idea. But equally, you de-skill on some of the other stuff, some of the stuff that is routine but equally important. And that's the balance that you're trying to, as a service, you're trying to cover. Difficult.
It is tough, isn't it? Yeah, but no, thanks. Yeah, no, it's a good answer to that question. So the next one is when should we call for a CCP or HEMS? Is it common for crews to not know their limits?
So I get this a lot actually, and I think a lot of people think that CCPs are just for cardiac arrest and major trauma. But there's so much other stuff that we can help assist with, decision making, a little bit of leadership, a little bit of just reassurance sometimes, And I think if crews are asking themselves questions like on scene, like we've got this patient a little bit sick, we don't really know what to do, we're stuck, they can get onto the critical care desk and ask some questions, and they can dispatch a CCP to assist with decision making, with extrication, with just a bit of reassurance, and no one would have any objections to that. But if you wanted to bypass the CCD, then with any patient that's sick, big sick, like severe asthma, life-threatening asthma, status epilepticus, we've got so many other like meningococcal septicemia, those sort of medical jobs that are tricky. Get us out. We're more than happy to come out and then be not needed than miss that opportunity. Like come back to the crew room and like, where were you? We were struggling on scene. But the other thing to consider is where you are geographically as well. Yeah. Like if you're 5 minutes from hospital to a hospital that can deal with that patient's condition, it's probably best for you to cut and run. If you've got someone, but conversely, if you've got someone who's centrally stabbed and they're peri-arrest, RVP with them en route, organise RVP via the CCD/HEMS desk, and get them sorted that way.
I suppose it's quite important, even for everyone, no matter where you work, to almost know where your CCPs are and what stations they run out of. And in where I work, the CCP is sort of probably about 15 miles away, which is quite a long time for the where I work. So it's not often that we see HEMS more than we do CCPs, because they can fly a lot quicker. Yeah. But then if you get pulled into an area that has a CCP, or your own area has a CCP, then you know where they all are and stuff. So it's quite good.
The other thing that happens quite commonly is crews will request a CCP and say we're just about to leave scene, and we go, okay, cool. The CCD will see where the crew is and where we are, and where they're plotting, sort of thing. And sometimes extrication takes longer than you think it's going to take.
Yeah.
So we can start heading towards where the crew are, and if they load and go, then the CCD the critical care desk can redirect us and sort of say they're going to meet you at a junction of the, wherever, and we can do it that way. But at all times, you've got to kind of bring it back to the patient and sort of say, where are they going to get their critical intervention in a timely manner, and how is that going to be achieved? If you ask those two questions, that will guide your decision making.
I remember that. I remember doing a ride out with you when I was a student, and one of the things I learned was that, I remember we went to a stabbing and he was conscious, alert, GCS 15, a little bit confused about the fact that he'd been stabbed. And I remember you saying, like, we backed up a crew on scene, and you were like, cool, let's go. And everyone was like, huh, what? Like, just looking at you, and you're like, yep, no, let's go. And you literally got this guy up, frog marched him out the house onto the back of the ambulance. It was like, let's go. And then afterwards, you're like, if he's up, he's moving, let's go get him to the care he needs. You're like, there's nothing I can bring to him here. He's been stabbed. He needs surgery and CTs, and we can't do that here. That's it. And it's just not delaying patient care. And I remember you saying to me afterwards again, if you wasn't there or whatever, it's that, and you come face to face with that situation, get the patient gone and liaise and meet en route. And
the stabbings are the ones that get under triage. It looks like a benign little line, on the patient's body. It can look like superficial, but you've got no idea how deep that object has gone, whether it be a blade, screwdriver, bicycle spoke, whatever, and you've got no idea what structures have been pranged underneath, and unfortunately, or fortunately, depending on how you look at it, the people that get stabbed tend to be young and fit, and they have big compensatory mechanisms and large physiological reserves, and they can hide the insult really well, and give you that full sense of security. But anyone centrally stabbed, if they can get into the back of an ambulance, then you 5 seconds on scene.
I remember looking at our scene times, and it was literally so quick.
I don't know if this is just like trust specific for me or whether it's like a national thing, but our trust say anyone who's centrally stabbed, your on scene time needs to be less than 5 minutes. Which kind of makes sense, but if you think about the difficulties,
what are you going to do for them there?
But if you, I've been to some stabbings where you go, oh sweet, you're standing, I'm not even going to bother checking your obs, I'm literally just going to get you straight in, strip you off, get you onto the bed, and I'll do it all on the way to the hospital. And you think, I'm 2 minutes away from like a hospital, I can, you get to the handover and you go, yeah, I've got this guy who's been stabbed here, I don't know the weapon, but the handover is pretty shoddy because of the information, but does that matter? Because they're in they're in a place of care where they can take them straight up to a theatre, So yeah.
Right, next question we had was, how do you remember all the knowledge and things you've learned throughout your career?
Wow, that's a good question. Governance helps, I try and every shift I try and open up one of the clinical management plans and go through a few of them, so it's fresh in my head. I read a little bit. I don't read as much medical stuff as I used to, but that does help. And the mental rehearsal thing is an important part of my practice as well. So, like mentally rehearsing challenging situations is good for me. And then, I might have to check myself and go, no, I did that wrong. I'm going to have to replay that. But that's the benefit of it. You can create what you want in your head, and then the governance is important, but because we're focused on the 1% of patients that ambulance service crews are going to, we can really focus on the big sick. It is a lot to remember, but this is my 23rd. Well, this is my, when did I qualify? I did my first CCP shift in 2009. So so it's been a while. So that, and it wasn't like when the first CCP came out, we didn't have all these CMPs. We had IV on Danzatron and a Lucas device, and that was it.
That's mad, isn't it?
And IV paracetamol, that was it. And now they're standard, as practice for normal paramedics. So it's great.
That's good. So really, it's just sort of constantly keeping up with the information and stuff,
recycling it in your head, and
that's the only way to do it. So the last question, someone, so they know, we know that you work on HEMS, or you used to work on HEMS. He said, "Do you hold a helicopter pilot license? If not, would you like to?"
No, I don't hold a pilot license. Would I like to? Yeah, I mean, it's a pretty cool job, and I know that the HEMS pilots that do it really enjoy it, and they generally come from quite a few of them now come from military background, and it's probably the closest thing from that.
Yeah, because I know that a lot of them have like ex-RAF and stuff like that, and
Navy,
but then if you think they've had to park a helicopter in like really difficult places in like Afghanistan or wherever, and it kind of applies here. If you I've seen them park in like people's back gardens, and you're like, and you see them coming into land, and you're like, they are not going to fit that in, but they do, and it's mad, you know, it's brilliant.
They do like pretty thorough risk assessment, and you know they've got an area that's pre-agreed, you know, what they'll land into, but they're looking for wires, they're looking for, you know, trees, they're looking for things that are going to blow away and stuff as they come in. But yeah, they're awesome and great guys, you know, really great guys to know. Always got a story to tell. I
know that HEMS have like specified parking spots around in the area, don't they? And because I've seen it on a governance day, and they gave out a little bit of information, and they was like, yeah, you know, these are all of the areas that we know that we can definitely park, and they said, oh, you know, there are some other areas, if you can think of any, then put them out on the map. And it was just an exercise, it wasn't like an actual official thing, but it was really interesting that they know that if they got a job in this place, they can park in this is the closest place we know that we can definitely park. It's like their plan B, I suppose, is it?
What they need to do next is they need to teach HEMS just to abseil down off the helicopter.
Nah, it's like an SAS,
no landing required, like
SAS paramedic. Yeah.
Kit dump, crew dump.
Yeah.
Like.
Well, there you go. I mean, I hope we finished it off with a good question. It was quite an interesting one, weren't it? But
thank you. Yeah, thank you so much for coming on, John. We really appreciate your time. It's an absolute pleasure to have you here. I'm sure we'll have you back again in the future.
Nice tea, by the way.
Oh, good. Yeah. But yeah, no, we really do appreciate it. You know, we don't know how to thank you enough, to be honest. But is there anything else you want to add, or?
No, it's been great. I've really enjoyed it, and yeah, you know, thanks for inviting me.
No, that's
our pleasure.
That's fine. Definitely our pleasure, and everyone else's, hopefully.
Thank you, John. Like myself, you know, a bit of an aspirant critical care paramedic. Hopefully, one day. It's been awesome I know I've not really said massive amounts in this episode, but it's been awesome to hear your points, and something I'm definitely going to take on board and moving forward. So thank you very much.
There you go. Thanks, John. Thanks for your time.
Absolutely. Don't forget to give us a follow, like and share on our socials at Bullhorns and Sirens or at Pocket Clinician. Thanks for tuning in, guys, and hopefully you'll catch us on the next episode.